Mm, good morning. Oh, let me click that. All right. Well, it could be evening for you. Anyways, um, we are on the final chapter. This is the treatment for psychological disorders. So I'm going to give you some various treatments. Again, wonderful chapter. If you're going to go into this field, there is an entire semester on psychological treatments. All right, so we're skipping through that. All right, so let's go way back in time. So back to the primitive times. All right, so many early attempts to cure mental illness were inhumane and unproven. So basically, we didn't have the techniques and tools that we have today. So there was this practice called trephining, and that's when people, doctors, whatever you want to call them, would drill holes in the brain, in the skull, to create these like exits for all these evil spirits to go away with people that had maybe schizophrenia, but we didn't know what it was. Turns out that doesn't work. Um, but again, way back when, that was abnormal. So it must have been some type of evil spirit. Asylums were obviously the places that housed those mental ill patients with those disorders. So in the 16th century, they looked like prisons. Asylums did. In the 17th century, um, a man by the last name of Pinel advocated for moral treatment of people with these mental illnesses. He believed that all people, no matter what, deserve to be treated, humanely and kind. In the mid 1800s, Dix over there, it's not to the left, it's to the right, well, depending on your screen, um, championed the mental hygiene movement in the United States. All right, so in the early 1900s, psychiatrists began to view mental health as a continuum. Like it just, it keeps going, so you got to take care of it. Um, and that's when classifying disorders actually started. So in 1952, the very first DSM, the Diagnostic Statistical Manual of Mental Disorders, was created. In the 50s and 60s, the US saw just a blowout of patients out of institutions and back into, you know, the normal world, I guess you could say. Um, and it was called deinstitutionalization because now we're taking the people out of the institution. This is just the graph to show you like the trend. All right, so in spite of deinstitutionalization movement, psychiatric hospitals and institutions continue to play an important role in the treatment of psychological disorders. Um, Not everybody goes into a psychiatric facility. One like circles of care, let's say, some volunteer to go into treatment, and some obviously either get Baker acted or Marchman acted, things like that. The length of stay is usually determined by what insurance is going to pay, unless you have money to cover these things. Um, and also, there is a restriction if there's not enough beds. All right, so boogie on. All right, so jail or mental hospital. So Dr. Jones Tapia is the executive director of the Cook County Jail in Chicago, where there's about 7,500 inmates at any time. According to her, about 20% to 24% of the detainees have a history of mental illness or they exhibit some type of symptoms of mental illness. But most facilities are just, they're not set up to rehabilitate people with mental disorders. They are, it's not, I don't want to say like it should be their job, but it's not, that's not what they're there for, to get rehabilitated. So obviously, we want that, and there's a big push for that. All right, and so today's treatment therapies can be categorized along three major dimensions: manner of delivery, the approach, and the perspective. So you've got the manner of delivery, the individual, whether it's individual or group, and then your approach. If you're looking at biomedical, we're looking at drugs. We're looking at different interventions that are going to hit different neurotransmitters um, that kind of help with that psychological disorder. So obviously the goal of using psychotropic medication is to alleviate symptoms of whatever the issue is. And then psychotherapy, also known as talk therapy, is this is where the client is going to address the issues with that, clinician, and talk about their symptoms and how to improve whatever is going on. And sometimes you need a combination of medication and therapy. All right, so you've got insight therapy, behavior therapy, eclectic, and what we call evidence-based practice, which is, got to do that. So insight therapy, those are the ones that are like, aha, where the client kind of goes, or not client, the therapist goes fishing, if you will. I learned this from my great mentor. So goes fishing and asks a lot of questions about, okay, when did this happen? Just probing, and to cause the client to start realizing their illogical thinking. They're like, oh, like I never thought of it like that. So again, it's to gain self-awareness about what's going on in your psyche. Behavior therapy, that focuses on changing your behavior. So like CBT, most common one, and that's challenging those illogical thought patterns to see that, okay, where's the evidence that this is true? And usually there isn't. It's that faulty thinking within yourself. An eclectic approach, that's what I use. I would think a lot of therapists use that, and that's using a lot of different theories, a lot of different approaches for that particular unique client, because one treatment is not going to work maybe with another, or one type of therapy might not work with another client. So there's a lot, I mean, a lot of different approaches that I can't get into in this, um, you know, lecture, if you will. But definitely, if you're going to become a therapist, you want to take that class, this class. So evidence-based practice, making treatment decisions that integrate valuable research findings, clinical expertise, and knowledge of a patient's culture, values, and preferences. So good evidence-based practice means that you can look at different treatment modalities and you can see that they have validity, that they have been used over and over again, and that the treatment actually works. And they are studies that look at culture and look at people's values, because everybody is different, and they take all of that into consideration. So psychoanalysis, way back when, my good boy Freud, he looked at the unconscious. So everything that's going on stems from way back here that's out of your awareness. And Freud proposed that humans are motivated by aggression and sex. He's the big sex dude. Everything relates to sex. Acting on these drives is not always compatible with social norms. So it's like, you can't do that because then everybody think you're crazy. So that's when the conflict arises and things get repressed and pushed down. And so because of that, it affects your mood and behavior. Psychoanalysis attempts to increase awareness of conflicts and work through them. So psychoanalytic theory, they really work on a lot of trauma, things that you have to dig down into the past to kind of pull that back into conscious awareness. This way you can deal with it. So again, psychoanalysis, this is Freud's thing. He was the couch creator, basically. I mean, he didn't create a couch, but his theory, where he would sit on that couch and you see there's a chair behind it, and he would sit back with his cigar and he would let the patients talk to him. So dreams are the pathway to the unconscious awareness. Dreams is another class if you're interested in studying dreams. Freud believed that dreams have a lot to do with, what is going on with you. There's manifest and latent content. These are kind of his go-tos. Free association, where the patient lies on the couch and just says whatever comes to their mind. There's a lot of interpretation going on. And there's resistance because sometimes the client is resistant to change, so they hold back. And then transference just means that, think about it, you're transferring your issues onto somebody else. And it could be that therapist, or it could be countertransference where the therapist is putting it on you. So, for example, let's just say a therapist is working with a client who has a major substance abuse disorder and also physical abuse, and maybe that counselor or therapist went through trauma herself. Maybe she had um, a spouse or a relationship where they also were a substance user and abuser and also physically abusive. That therapist could do what's called countertransference and look at the client differently. And that is a big no-no. So clinicians have to always put themselves in check. Right, so you have psychodynamic theory. So those are the neo-Freudians that said, okay, Freud, you had some good thoughts, but you kind of cuckoo-cuckoo, and we're going to take out the sex part and replace it. So this type of insight therapy incorporates the core psychoanalytic themes that includes that personality and behaviors frequently can be traced to unconscious conflicts from our past. But here's the little stuff. So psychodynamic therapists tend to see patients for months, not years. They sit face to face with the client, not behind them, and then they address specific current problems, not things from the past. So again, shorter, face to face, and let's get this done here and now, and not we have to revisit the past, but we don't get stuck there. Humanistic therapy, this is Carl Rogers, the most beloved psychologist that ever lived. There was this big movement in the 1950s. This type of therapy is also insight therapy. It emphasizes positive nature of humankind. So basically, this dude looked at everybody that everybody has should be treated with empathy, positive regard, and respect, and all of that stuff. So he's one of the founding fathers, believed that all people are fundamentally good and capable of self-actualization, and basically just striving to be their best self. His type of therapy was called person-centered. He developed it, and this was aimed at helping his clients achieve their very full potential through a lot of talking and discussing. So we all have a natural tendency towards growth and self-actualization. Again, that's in Maslow's hierarchy of needs, where we self-actualize, we be the best that we can possibly be. We live up to our own unique potential. Family and society may hinder growth and can cause an incongruence between ideal self and real self. So we have to check that and make sure that, okay, what is holding us back? Who may be holding us back to become who we want to be? The main treatment goal is reduction of that incongruence between those selves. It's non-directive. And what that means, so this technique is person-centered, where the therapist is going to follow the lead of the client. So instead of the therapist directing, it is the client directing, and the therapist is just kind of along for the ride, just kind of guiding in the pathway and doing a lot of listening. So when you look at this type of treatment, you want to build an alliance with your client. So empathy is the ability to feel what they're experiencing through their eyes. They're painting the picture and you're seeing it through their lens. The unconditional positive regard, completely accepting that client no matter what they say, how horrific it might seem to you. And you can see that in chapter 12. Having a deep genuineness, so being completely authentic, responding to the person in a way that's real, rather than just putting this facade and just being like, yes, oh. You want to actually be real with them, because it makes them feel like, okay, they're really hearing me and understanding me, and which in turn causes them to open up even more. And then active listening is picking up on their emotions, and understanding what they're saying. And the key of that is reflecting and echoing. So restating what they have said to you. And that really tells them that you are listening to them by saying, okay, so what I heard you say was, and then they're like, okay, they really are listening to me. All right, so strengths of insight. Freudian theories help therapists understand past experiences. Psychodynamic therapy may be effective in treating a bunch of different disorders. Humanistic techniques have helped therapists of all persuasions build stronger relationships. It's more of a strong relationship builder. Limitations, difficult to study their effectiveness because it's not operationalized. There's no like, independent, dependent variable thing going on there. And it does vary from one therapist to the next and how they use it. Insight therapies demand high levels of verbal expression and awareness of self and environment. So that type of therapist has to be very self-aware of their own internal things going on and their own biases. All right, so your exposure and response prevention, so there's your behavior therapies. That technique brings a person into contact with a feared object or situation in a very safe environment. And the goal of that is to eliminate that fear response. Works very well with the phobias, which we'll go there. Particularly intense form of exposure is to flood the client with an anxiety-provoking stimulus that cannot be escaped, causing a high degree of arousal. Now, I don't know of anybody that does this. I don't think it's very ethical to flood somebody. That's basically just taking their whatever and just raining it on them. And that can cause a lot of issues. So what you really want to do is take those little small steps. So again, if we're working with phobias, let's say, and someone is phobic of like a snake, because that's a big one, you would talk first about the snakes, talk about the anxiety provoking issue. Then you would show them a picture of a snake, right? Then maybe it would be a small picture, increasing to a larger picture. You see where I'm going? Then maybe eventually you would show a video of a snake kind of moving around in live whatever. And then to eventually maybe a snake in a cage where they're actually exposed to what they feel is the threatened situation. So you have to create the hierarchy. So you get them like here, then you stop. And then you pick it up the next session. Then you go higher and higher until they can actually deal with it, and then the phobia distinguishes. Virtual reality, VR, is also a great way. It's putting on those fancy goggles and traveling in a virtual world where you take the feared object that's not real, but it's real to them. And, driving over bridges, planes, all kinds of phobias. So studies indicate that virtual reality exposure therapy may be effective for treating a variety of disorders, agoraphobia, social anxiety, and phobias like public speaking, heights, and spiders. Social anxiety, a really good one because, people do suffer with that a lot. So virtual reality, putting them with like avatars, that's what they would use, not real people, and exposing them to that type of reality, and you're kind of walking through that, addressing that. Systematic desensitization, treatment that combines anxiety hierarchies with relaxation. So you get them anxious, and then you get them relaxation techniques. Uses progressive muscle relaxation, where they like tense up, and then you get them to relax. So over multiple sessions, the therapist guides the client through this hierarchy again, encouraging the client to employ the relaxation techniques when anxiety sets in. Aversion therapy, used a lot with people with alcohol use disorder. It's a therapeutic approach that uses classical conditioning to deal with those unpleasant reactions, physical reactions. So alcohol is one of those. One type of aversion is anabuse. That's to get the person to quit drinking. So basically, you take the medication, you drink, and it's like you want to just throw up. It's disgusting. So it like causes you to not want to use anymore. All right, I'm going to do a quick pause key. Pause key. I'll be back. Hello, I'm back. Sorry, I had to take a little break ski because some of my students walked in. They're taking their ACE exams. All right, so aversion therapies are only effective if the client is motivated to change and complies with treatment. So, I mean, if the person really wants to quit drinking, obviously, I'm sure we all know somebody that struggles with addiction, whether it's substance abuse or alcohol, which is a substance. But again, aversion therapy only works when the person is motivated. All right, boom. Behavior modification, like a token economy. Um, this is an approach where the behaviors are shaped through reinforcement, through operant, what they call operant conditioning, to change those maladaptive behaviors. Some therapists also incorporate observational learning. Token economy is a type of behavior modification, uses tokens to reinforce that desired behavior, very used in AA. So for every day that the person doesn't drink, they get a token. Then they get like a special 30-day token and 6 months, a year, stuff like that. Some critics think that it's manipulative. I'm not really buying that, but it's widely used. Cognitive therapy, good old Aaron Beck. Now I think he's like 100 years old or 99 or something like that. He's kind of the guru of that. Um, if you've ever, CBT is the most widely used therapy, and his triad, believes that patterns of automatic thoughts lie at the root of psychological disturbances. So basically, that is your logical thought patterns of this stinking thinking that's not, I don't want to say it's not real, but it's like, okay, where's the evidence of that? So these, what they call cognitive distortions, which is thoughts, or errors, cause individuals to misinterpret events in their lives and are associated with psychological problems like depression. So people that suffer with depression, CBT is used a lot. And overgeneralizing is one big thing of these distortions. We overgeneralize things that are not as big as they seem to the person. Okay, so here is some cognitive distortions that you can kind of look at. So you got arbitrary inference. The example is, I'm a horrible student. Look at the explanation. I'm just going to tell you the example. Selective abstraction. I know he's cheating on me because he's emailing a woman at work. Maybe he's emailing her about work stuff. I'm just saying. Overgeneralizing. My boss doesn't like me. I'll never be liked by anybody. So you take that one event and you just exacerbate it. Magnification. Think about magnifying like a glass, taking a small thing, making it bigger, or minimizing, taking something and making it smaller. So if I don't pass this first quiz, I will fail the course. So it's like taking one event and just saying, okay, I'm going to fail the whole thing. Or minimizing, hey, you did great on that test. And instead of saying, like, I studied hard, you would say, well, I just got lucky. So that's what that means. Dichotomous thinking, I can either be at the top of my class or I can get married and have a family. So it's like, okay, it's like, it's incongruent. Personalizing, I waved at her, but she didn't even acknowledge me. I must have upset her. So those are just some examples of cognitive distortions. Kind of want to know those. All right, REBT, I'm going over that extensively right now in my class. It's Albert Ellis's form of therapy that he came up with, rational emotive behavior therapy. That's a type of cognitive therapy. It identifies illogical thoughts and attempts to convert them into rational ones. So it kind of mirrors CBT a little bit, but REBT is more challenging and more direct. So it's like, okay, so what if she doesn't like you. What's the worst that can happen? Instead of, so it goes a little more extra. They use the ABC model. It's a very effective model. The activating event, then based on that event, what is your belief about that event? And then what is going to be the consequence of that event? So you dispute those flawed beliefs. And when you practice that ABC model with a therapist at first, of course, then you develop a new philosophy of thinking. So here's a little chart ski. So you've got a negative event, I got fired. The belief about that event is I'll never get a good job. And then the consequence, you feel hopeless, depressed, and you just don't want to do anything. Disputing that belief, getting fired once does not mean that my career is over. It just means maybe this situation happened, but I can rectify and maybe change this for the future. And then the effective new philosophy is I'll find another job. I'll just apply somewhere else. All right, CBT, it's action oriented, requires the client to confront and resist their illogical thinking. It works quickly. It's the most widely used among clinicians. Both Ellis and Beck's theories are considered cognitive behavioral therapies since they incorporate a focus on both behavior and cognition, but they are both very separate things. Most psychotherapy takes weeks, months, or years to produce a benefit to clients. Short course therapies for anxiety disorders have begun to catch on in the United States and Europe. Generally begin with psychoeducation. That means giving education to clients about things, about what disorders are, about what the myths are, and things like that. A second part usually involves exposure and response prevention. Patients leave with homework to reinforce the lesson. So it's not homework like in school, but therapists effective therapists should always give homework to give you something to work on to get better. 2017 meta-analysis, that basically what that is a collection of a bunch of studies, found that brief, intensive, or concentrated therapies for childhood anxiety disorders were comparable to standard CBT. All right, so strengths, they work fast because they're used in behavior therapy. They're often easy to operationalize. It's short term, it's effective. All insurance companies pay for it. Weakness, the goal of therapy is to change the learned behaviors, but not all behaviors are learned. So you got to remember and think about which behaviors are not learned. Okay? Think about that, because that is not a CBT technique then. Because reinforcement comes from external source, newly learned behaviors may disappear after that reinforcement is stopped. Difficult to discern if distorted thinking causes mental health issues or whether mental health issues cause distorted thinking. Right, your biomedical therapies or your drug therapies, ECT, and surgery. So psychopharmacology is basically the use of medications to alleviate depressed moods, change behaviors, and other areas of psychological functioning. Medication is prescribed by psychiatrists. They have a medical degree. Psychologists do not prescribe medication. They do therapy. Only a very minimal amount in not very many states. They're divided into 4 categories: your antidepressants, your mood stabilizers, your antipsychotics, and your anti-anxiety medications. So your antidepressants, those are your psychotropic medications that improve mood and anxieties and eating disorders for certain people, not used a lot. You've got your MAOIs and your SSRIs. Your MAOIs are your older treatment options, and your SSRIs are your newer ones. Those are your SSRIs are things like Celexa, Prozac, Zoloft, Lexapro, Paxil. Your MAOIs, there's like Nardil, I don't remember what the other ones. They're not used as much, and they break down certain neurotransmitters so that serotonin and dopamine and all those things are more enhanced. All right, so all of these antidepressants are thought to work by influencing the activity of neurotransmitters. So the question they ask is, can you identify safety concerns or side effects for each class of drug? Because some medications can actually do the opposite. So instead of, it's meant to lower depression and lower suicidal thoughts, some actually flip and increase that. So sometimes you have to try different medications that will help. Your mood stabilizers used with bipolar disorder, they don't fix it, but what they do is they stabilize the mood. So the highs aren't so high and the lows aren't so low. Anticonvulsants may also be used to treat mania. Some may increase risk of suicide. Your antipsychotic drugs are for like schizophrenia, hallucinations, delusions. They function as dopamine antagonists, reducing dopamine activity. Then you have what's called tardive dyskinesia. That's a neurological condition stemming from use of traditional antipsychotics, whose symptoms include shaking, restlessness, and bizarre facial grimaces. Although these drugs reduce symptoms in 60 to 85% of patients, they do not provide a cure because psychological disorders are not cured, they are maintained, stabilized. Your anti-anxiolytic drugs, those treat anxiety, phobias, things like that. Most of those are called benzos or benzodiazepines like Xanax, Valium, Klonopin. You have to be careful. They work fast. They're highly addictive, especially if you have an addictive personality. They enhance the neurotransmitter GABA. And then benzos are potentially lethal when you mix them with alcohol. So if you're taking benzos, you don't want to be drinking with them. Okay, research suggests that psychotropic drugs are most effective when you use psychotherapy. Basically, it's like a Band-Aid, just the medication alone. So you want to kind of take the medication to alleviate the symptoms, but then you need to talk about them so that you can get through them and understand why they are so that you can deal with them and move on. And especially with depression, maybe getting off of the depression pills once you work on what it was that caused it. So combining the two include cognitive, behavioral, and psychodynamic perspectives, reduces major depressive symptoms, than just doing one or the other alone. Medications affect people different ways, so dosages must be assessed on a case-by-case basis. So usually people start at a lower dose and then work up. All right, we are going to skip that. Your ECT works, through all of these years of study, found that ECT works highly effective with major depressive disorder. It's not like it used to be with schizophrenia where your whole body was zapping. It's not like that. Biomedical treatment of severe depression, it induces seizures in the brain through small electrical currents. In the US, patients undergo 3 treatments a week up to a month. Kind of the downside of that is it works kind of like in the here and now, whereas medications work longer term. And then you've got neurosurgery. Biochemical therapy involves the destruction of some portion of the brain or connections between different areas of the brain, like prefrontal lobotomies. It is definitely the last resort. All right, we're skipping that. Should therapists and clients be matched according to ethnicity? No, that is not. Sometimes people, like some women want to see women, some men want to see men, some Black women want to see Black women, or, gender, whatever. The thing is, it's kind of few and far between. They're getting more. But, I had an Asian client once, beautiful woman, and she really tried hard to find an Asian therapist, but she just couldn't find one. And so the thing with culture conscious is you don't need to be that person's ethnicity or race, but you do need to understand their culture and be very cognizant of that. You need to understand, maybe depression in this culture doesn't look like it in that culture. So it's educating yourself to know their culture. So it's critical that therapists be cognizant of their own, I didn't even realize I wrote that there, cognizant of their own cultural biases and sensitive to the many forms of prejudice and discrimination people experience. And then you've got your group therapies. Those work great when they're cheaper for the client. They give people insight into each other's world. They can have 3 clients. Ideal is 6 to 10. And that's when people share their issues and problems together in an open, safe environment. Research shows that group therapy is effective as individual therapy for addressing many problems. Your self-help groups, they're not trained clinicians, but those are groups like AA, Weight Watchers, Parents Without Partners. It's often led by one therapist or clinician that's kind of the liaison and kind of just interjects when needed, but the group usually runs itself. Family therapy focuses on the family, the whole system. It's not one person that causes the breakdown, it's the whole family unit. So, looking at interaction. So, because families typically seek resolution of a problem, the course of therapy tends to be brief. And there's all kinds of family therapy, like equestrian therapy is really amazing. Couples therapy, I don't mess with that. You can look into that. These are the things that they address, but I my bell's about to ring. So I usually not farm out, but I usually, what's the word I'm looking for? Look at your strengths and weaknesses. That's our bell at O'Galley High School. Listen to this. That's our bell. You might think it's cool, but when you hear it every day, no fun. I hope I'm done. Go ahead and pause this. Look at strengths and weaknesses. I'm gonna have to go because the bell's ringing, and I thought students came in, so I got sidetracked. All right, so does psychotherapy work? Yes, it does. Go ahead and look at this on your own. Pause it. Um, Help when you need it. If you need help, get it. The stigma getting smaller. If you think you need help, what should you do? Look around. Find the right therapist. Number one, when you're looking for a therapist, kind of stay away from the ones that say they can treat everything because that's not true. You want to find a therapist that specializes in the thing that you need. Nobody can specialize in mood disorders and depression and schizophrenia, and they specialize in limited. So that's important. Just because somebody has all these things, no, 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 no. Online therapy, therapy, that is really huge right now, especially with COVID. It was before that, but now it's like booming. So go ahead and look into e-therapy. The thing that I will just say real quick before I have to open my door is that you do miss a lot of that body language. So you just have to really know what you're doing and ask the right kind of questions. I kind of like it, but I only do it when absolutely necessary. You can take a look at this, social media and psychology with Facebook. You can pause. Okay, I'm not pausing. And I should be done. Whoo! Now I can go get my kiddos. All right, you know what? You know what I'm going to do, right? Okay, have a wonderful day and peace out.